Now this is a discussion on venous thromboembolism. As you can tell, venous means in the veins, thrombo, basically blood clotting. Think of thrombin or thrombomodulin, those kinds of things. And embolism, of course, is where it breaks free and goes somewhere and causes damage, gets stuck somewhere. So first of all, did you know this is a really serious disorder or serious disease, whatever condition? Apparently in 2012, there was over 500,000 people that had new development of this condition. And there was also a third of a million, about 275,000, who had recurrent DVT, or VTE rather. And apparently a quarter of a million had a DVT. So the DVT is the most serious, even though it is the smallest out of the group here, because about 30% of these patients who have this die within 30 days. And the reason why they die is because of pulmonary embolism. Just think of it this way. Where do all your veins go? Your veins are all deoxygenated blood, and so they need to carry the blood back to your lungs. Once they get to your lungs, they can get oxygenated again. And so typically, almost all venous thromboembolism originate in the blood vessels in your legs, like 10 times more often than in your arms. Although, inline catheters and things that they're doing nowadays are increasing in your arms. But still, it's like 10 times more likely to happen in your legs. So it goes from your pelvis, blood vessels, or any of those big ones in your legs, and it goes up and it gets to your lungs, and it gets clogged right there where the blood vessels branch out to go into your lungs, and you die from pulmonary embolism. 70% are from the pelvic and deep veins of the legs. So pretty much all of the people who get the pulmonary embolism, it's going to be 70% is going to be from the pelvic deep veins of the legs. So the most common preventable death in hospitals is pulmonary embolism, complication of deep vein thrombosis or venous thromboembolism. Usually what happens is most commonly it's going to be from recent immobilization, meaning the person was on an airplane for a long time, or they just had surgery and so they're laying down a lot, or they're pregnant, or these kinds of things. I also mentioned something about sex hormone there I didn't quite understand. Differential diagnosis, when somebody comes in and they have unilateral leg pain and swelling and redness, is you're going to think, well, maybe this is a ruptured Baker's cyst, or maybe it's cellulitis, maybe it's post-phlebitic syndrome. That's going to be kind of a differential diagnosis for that. But you recognize that pulmonary embolism looks like a lot of other things. Pulmonary embolism can look like heart failure. It can look like acute coronary syndrome. It can look like pneumonia. It can look like COPD. It can look like pericarditis. They call it the great masquerader because it looks like so many other things, but it's so deadly and kill you so fast. Deep vein thrombosis can be kind of ruled out, though. There's some one technique to kind of determine whether a person has it. It rules out patients with a decreased probability is the Wells clinical decision rules. You can also do the D-dimer blood test. The D-dimer blood test has apparently about a 95% specificity and about an 80% sensitivity. But that's with DVT. With pulmonary embolism, apparently it has 100%. The treatment, also you can determine whether somebody has DVT by doing a duplex ultrasound, and that has about 90 to 95% specificity. Treatment is going to be, prevent clot propagation. You don't want the clot to get bigger and break loose and go somewhere. So one of the ways to do this is through anticoagulation therapy. Before they used to use thrombolytics. The problem with that is that it was giving a lot of people cerebral hemorrhages and things like that. So they've kind of stopped doing that unless it's like really serious, or the person has partial heart failure, or they had a myocardial infarction, or they elevated levels of different things that could, make it difficult for them to do the other forms of treatment. But a lot of times what they'll do is they give people intravenous unfractioned heparin from injection, and so typically it'd be like the two ones that are FDA approved for this are going to be enoxaparin and tinzaparin. Also, prophylactically, you can give somebody, let's say somebody had knee surgery or something like that, you can give somebody dalteparin. If, I guess in the case if they have cancer. So if somebody has cancer, give them dalteparin. If they're also having a risk for VTE. Fondaparinx is another drug you can give people. That is a factor 10, an activated factor 10 inhibitor. But pretty much all these you're going to give the person with, in a combination with warfarin. And something about that being after 45 days. But you give the person warfarin for up to like 3 to 6 months if the person has venous thromboembolism, which is the same thing as DVT, by the way. You can also, there's some new drugs here for oral ways of giving it to people, which is, I hope I pronounce these right, dibigatran. That's typically for people at risk for strokes. Or you give people oral rivaroxaban, which is a 10A inhibitor. And if you notice here, it ends in, it's rivaroxaban. So it has this XA ban. And that might help you to remember here if you think of this being factor 10 ban. It bans factor 10. X Roman numeral for 10, because rivaroxaban is a 10A inhibitor. So if you see something with XABAN in it, think that it's a 10A inhibitor, which is part of the coagulation cascade. Also, nowadays apparently they give heparin to practically everybody that goes into the hospital for some reason. That's just prophylactically treating just in case they get a venous thromboembolism. And apparently it's decreased, since they've been doing that, it's decreased venous thromboembolism by like 40 to 50%. Lastly, just a little quick discussion on chronic venous diseases. For this, a couple disorders of the veins or lymphatics. One of them is going to be superficial venous thrombosis. This usually occurs in the calf. It's thought not to cause a pulmonary emboli. Therefore, it can be treated with local heart elevation aspirin. So you just give it, give the person some aspirin and local heat. So just put some heat on their calf, elevate their calf, and give them some aspirin. They should be fine. Sometimes the thrombosis of the great saphenous vein in the thigh are treated with heparin to reduce the likelihood of progression. So if it's in the thigh, you can give them heparin. Varicose veins is another really common one. For varicose veins, a lot of times you see this in pregnant women. What you can do is give them compression stockings. Sometimes they can do sclerotherapy, radio frequency, or laser ablation, or sometimes you can do venous stripping. And one of the comments on this one is this: everything other than the stockings is going to decrease the successful coronary artery bypass surgery later in life, because you're destroying blood vessels of the legs, which might be used in a coronary bypass surgery. But anyway. Side note, next disease here is chronic venous insufficiency. This most often occurs after deep vein thrombosis and recanalization of the vein. Current classification of this is done by the clinical, etiological, anatomic, and pathophysiologic. We're not going to worry about that. Anyway, just note there. Lymphedema also can occur here, and that's a primary form of it. Could be congenital or whatever. Anyway. So, yeah, that's pretty much all I've got on that. I guess I'll close out.